Hello guys, a very good evening. Welcome to Dr Ranjith here again. So today we are going to see in the session 2 of study with me. Yesterday we had a quick look about iron deficiency anemia. We actually went in detail about iron deficiency anemia, right? And today we are going to see about your hemolytic anemias. So this is the second part of RBC disorders. We'll be discussing about every hemolytic anemia in detail. And tomorrow and day after tomorrow we'll be doing WBC so that we can wrap up the entire RBC and WBC session. And by the end of the 4 days, we'll have a quick 20 MCQ session which will be hosted in the Unacademy app. Fine. Okay. So I urge you to download the Unacademy app and you can complete the RBC and WBC, the hematology with upcoming exams. And we should go and do the MCQ so that it will help you to revise many things very quickly. Fine. Okay. So without any delay, we'll go to hemolytic anemias. So what we are going to discuss in hemolytic anemias is, first we'll be looking at the classification. How I can classify hemolytic anemias. There are two bases of classification. One on the location of hemolysis. I can go with the intravascular hemolysis and extravascular hemolysis. That's one. The second part being based on the RBC abnormality, whether the abnormality etiology based classification, whether the abnormality is in the RBC intracorpuscular or the abnormality is coming outside from the RBC extracorpuscular. Right. Once the classification is sorted, we'll have a quick look about every hemolytic anemia. Right from the pathogenesis, we'll have the same template. Look at the etiology, pathogenesis, diagnostic point, clinically, lab diagnosis, maybe your peripheral smear CBC, any particular specific test. For example, there's something called a meth hemoglobin detection test for G6PD. We'll look at that and then investigation of choice. Right? And to finally summarize it, we'll also have a quick look about the treatment aspects. So though I'm not going to much talk about the treatment, just something in link with the pathogenesis, we can easily go with the treatment as well. Fine. So if you're ready, let's start. Okay. So first thing, I said that we are going to have a quick division about hemolytic anemias. The one thing is based on my etiology. So the classification of hemolytic anemia. So we're going to divide the classification of hemolytic anemia into two things, as I said. One will be etiology based classification. One will be the lysis based classification. The location of lysis, right? Location of lysis based classification is the other one, right? Let's say etiology. What is the problem? Exact problem based. When I say lysis based classification, intra or extracorpuscular. First, we'll have a quick look about the lysis based classification. When I say intravascular hemolysis, the lysis of the RBC, whatever may be the pathogenesis, is going to happen in the vascular channel, in the blood vessel. Say extravascular hemolysis, it's going to happen predominantly in the spleen. It's not always it should be in the spleen. It can happen in any your reticuloendothelial system. Apart from the blood vessel, happen in liver, your spleen, lymph node, anywhere. But predominantly we consider spleen, right? So when it comes to an intravascular hemolysis, we'll look at this first because my signs, symptom, everything will change based on the location of lysis. Let's take I'm having a tiny little bit of RBC, having an intravascular hemolysis. So if you have an RBC just like this, it's going to lie inside my blood circulation. The first thing what's going to happen is the amount of hemoglobin which will come outside in the plasma or serum increases. We call them an hemoglobinemia. The amount of hemoglobin inside the serum increases, not inside the RBC, it comes outside, right? So I'm having hemoglobin in the serum or the plasma. So what is going to happen is it automatically divides into two things. One is my heme, other is globin, right? So the globin will be reutilized. So it's just a protein, plasma protein, which is going to be reused, right? I don't have any problem in the globin, it will get reused. The next is the free heme. The free heme is a toxic person. It might cause a free radical induced damage to other cells. So what I have to do is, I have to make sure I'm going to use or change the free heme to some other component. Because otherwise it might be detrimental for us, right? So what I'm going to do is, I have two ways where I can divide the free heme. One is I can divide them or I can convert them into your haptoglobin, will bind with haptoglobin with a compound and it's going to make it less toxic. So what I'm going to do is I'm going to consume the free heme, a haptoglobin, and bind to it and make a complex. So it is not available free, so it will not die. So what do you think will happen to the levels of haptoglobin, right? What do you think will happen to the levels of haptoglobin? It will be reduced or elevated? You know that it's going to be reduced, right? So this is one of the pointers for me, right? This might be a question. the levels of haptoglobin will reduce in response to an intravascular hemolysis, right? The other person is, again, free heme is toxic for me, so I'm going to convert into another person, which I'm going to call it a methemoglobin. When I convert to methemoglobin, it's going to become increased. The amount of methemoglobin will be increased. Again, methemoglobin is less toxic compared to my free heme, right? So these are the ways I'm going to reduce the toxicity of the free heme, that's all, fine? Not only here, I have the same free hemoglobin. This free hemoglobin in the serum can get filtered, right? My kidney can easily filter it. Once my kidney filters this, what's going to happen is it'll go through the kidney, it'll go in the urine as well. So I'll have hemoglobin urea, fine? That's other finding here. I'll have hemoglobin urea. See, this is a very, very important finding. Once in a DNB exam it came. How do you think a patient will present to you with hemoglobin urea? The patient will tell you only one thing: the patient has blood in the urine, that's all, right? So in the blood in the urine, I'm going to say that it is definitely hemoglobin urea, or I can call it an hematuria as well, something, right? So clinically, the patient will tell me only one thing: see, I'm having hematuria. So once you have hematuria, the first investigation any doctor is going to do is they are going to give you an, let's say, an urine examination. When you're going to have a urine examination for a patient who's ideally having hemoglobinuria, I will not know that with the history, right? So will you see RBCs or not in the microscopy? Will you see RBCs or not? Just answer whatever comes to your mind. Perfect. SNS opened the account. We will not see RBC. That's a very important MCQ for you, right? I want you to remember this. Perfect. Good. So you have a clinical history of hematuria. This is what the question came. The patient gives you a history of hematuria, plus there are no RBCs in microscopy. I want you to suspect hemoglobinuria. Don't say that it's a wrong disease. It could be in hemoglobinuria. Why I want you to know this is, this might be a practical importance for me as well. Don't think the patient gave some other urine sample. Ask the lab to investigate for chemical tests for hemoglobin. That might be positive. This is very, very important for you to understand, right? Let's come back to our hemolysis. So I'm having hemoglobinuria here. So it might go back. So my glomerulus has filtered it. So what do you think other findings will be? Good. SNS come a little bit ahead of time, right? So what's going to happen is I might have hemoglobinuria, not only hemoglobinuria. Sometimes the amount of hemoglobin which is filtered by the glomerulus can be taken back by my PCT, right? So I can have a reabsorption by the PCT. In the PCT, it will be stored as hemosiderin, right? Once it's stored as hemosiderin in the PCT, and PCT will have a half-life, right? Obviously, will have a half-life. Once that half-life gets over, the proximal converter tubule cells will die. So I'll take the hemosiderin along with the dead cells and go in the urine. So I'm going to have an hemosiderin-urea, right? So that's perfect. So these are the findings I'm going to see in a case of an intravascular hemolysis. Okay. So you'll have hemoglobinuria, hemosiderin-urea, hemoglobinemia. That's where we started with. We'll have reduced haptoglobin and we'll have increased methemoglobin. One thing which is very common for any lyse cell is LDH, right? The lactate dehydrogenase levels will definitely be elevated because that is very, very common for almost every lyse cell, not just your RBCs, anything, right? So these are the changes. What's going to happen in your intravascular hemolysis. When I say the lysis is going to happen in the extravascular space, extravascular hemolysis, as I said that the predominant hemolysis happens in the spleen. It's not just in the spleen, it's inside the spleen. It happens in the littoral cells of spleen, right? The splenic macrophages are called as littoral cells, right? So I'm having a macrophage here. So all the lysis happens inside this. So do you think anything heme will be outside the in the serum? It won't. So nothing is going to happen. The only thing what's going to happen is because of the extravascular hemolysis, the spleen function is going to become more. When the spleen functions more, the only finding I'll have is splenomegaly. Okay, this is the only finding which is especially specific for an extravascular hemolysis. Right, that's important for me. So for both extravascular and intravascular hemolysis, I have a common triad for any hemolytic anemia. See, this triad will be common for any type of hemolysis, both intra and extravascular hemolysis. The first one is there will be a reduction in the lifespan of the RBC. Obviously, right, my lifespan of RBC will be reduced here, right? So second thing for me here is you will have an accumulation of bilirubin or my hemoglobin degradation products or an heme degradation products. The heme degradation products will accumulate, right? That's the second one. Third one for me is your retic count. The bone marrow will definitely respond to it. So you will just within a quick time we'll go and entirely look about what's going to happen in your lots of there is a thing called as in reticulocyte correction. We'll just have a look at the retic count, fine. So what's going to happen here is I'm going to have an increase in the bone marrow hyperplasia, which can be easily detected by an retic count, right? I have an elevated retic count. So what we are going to see now is how I am going to use my retic count correction for me for diagnosis, because we have read about reticulocyte count in many places. Retic count correction, we have not spent much time to learn about it and to understand about it, fine. So in the next few minutes we are going to discuss about the reticulocyte correction, okay? So there's a common thread for everything and it's seen only in extravascular hemolysis, and all these findings are going to be seen in my intravascular hemolysis, right? So my lysis based classification of extra and intravascular hemolysis holds here, right? So next thing what you're going to see is, as I said that I'm going to go towards something called as reticulocyte correction, and this is important for me there because see, when I say reticulocyte correction, I'm going to have two corrections in reticulocytes. My first information is why should I have a reticulocyte correction? Is my first query, right? Why do I need to correct it? Let's say that a lab is giving me a value of a reticulocyte percentage. They have looked into the microscope, or there are lots of automated machines which can give me my reticulocyte count. My requirement of why I need to have a retic count is my bone marrow is responding to the anemia. I need 1 unit response. I need not have the entire response. So what do I mean by that is, let's assuming I'm having a bone marrow here. There's a simple bone marrow. The patient has an hemoglobin. Let's give different patients. One patient has 10 hemoglobin, one patient has 11, one patient has 8, one patient has 6. I have different hemoglobin levels here. Based on this, let's assume that 10 hemoglobin, it responds 2x. Here it responds 1x. Here it responds, let's say 4x. Here it responds 6x. So based on the severity of hemoglobin, my bone marrow is going to respond to different amounts. I don't want that. I want per unit retic count. Because only when I know per unit retic count, I can judge that, okay, this person's bone marrow is going to compensate this much. So I give support a little bit, I can overcome the disease, right? My ultimate goal is to overcome the disease. I need per unit retic count. So what do I do in first correction is, in the first correction, it's very simple. I need per unit, right? That's all. So what I do is the retic count will be given by your patient. So in the lab, let's say the retic count is 10. Okay, the retic count given by the lab is 10%. It's definitely high. The normal retic count being, what is the normal retic count? Can you comment? It's a very simple one. Normal retic count is great. Normal retic count is like 1 to 1.5%, right? So 10% is definitely high. So what I do in first correction is, I'm going to take, there's a first correction. It's also, I can call it a corrected reticulocyte count. I'm going to say that it's the normal retic count of the patient multiplied by hematocrit or hemoglobin. That should be given in your question. It will be there in your question. Divided by the standard hematocrit or hemoglobin. Okay. I generally prefer hematocrit over hemoglobin because I'll just go to the left once, because the second correction is based on hematocrit. This is my second correction. This is totally based on hematocrit, right? That's why I prefer hematocrit than hemoglobin, but it's completely fine. Whatever it is, you can use, right? So hemoglobin also can be used. My hematocrit also can be used, fine. Generally, we use hematocrit in a real life scenario as well. Let's assume that I'm just giving you a random value here. Let's say that retic count here is 10% and the patient's hematocrit, let's say it is 25% here. It's an adult male, so I consider normal hematocrit as 45%, right? Just for that sake, okay. I should be able to do the mathematics here, okay. Let's cancel it for 9, okay, 10, and this is 5, fine. Maybe approximately this will be 1.1 or something. So 5 into 1.1, I'm saying approximately 5%, fine. So after the first correction, what has happened is my retic count has dropped to 5%, which means that it's just 5% is the response of per unit of the bone marrow change here, right? Just 5% here. This is first thing. So what I do in second correction is, Second correction happens for the duration of reticulocytes. Duration or lifespan of reticulocyte. Okay. So it just happens for the lifespan of reticulocyte. See, when you say lifespan of reticulocyte, what do you think is the normal lifespan of reticulocyte? I'm sure you guys know that. The normal lifespan of reticulocyte, approximately a day, right? It's not going to be more. It's just going to be approximately a day will be the normal lifespan of a reticulocyte for any adult person, right? Again, all these calculations for adults. For neonates, it will vary a lot. Even normal reticulocyte count also will vary in a neonate, fine. So my lifespan of reticulocyte is 1 only. So again, why I need this correction is what I'm going to look first. The second correction, the requirement, right? Let's say that today is November 30. So for a normal person today, November 30, I will look at the reticulocyte which was produced in 29th November, that's all. Whatever retic was produced in 28th November would have become mature RBC now because the lifespan is just a day, right? So in other words, when I'm having hematocrit, the degree of anemia, right? I'll go back to the slide, what is given in the left hand side, or the correction factor. I hope you're able to see this. Based on the hematocrit, the lifespan of the reticulocyte increases. If you have a look, it's written there, if my hematocrit is 45, the lifespan is 1. That is normal, right? If the hematocrit drops to 35, lifespan becomes 1.5. 25, lifespan becomes 2. Right? So I need this change. Why this is very important for me is, let's assume the patient has 25% hematocrit. Our example, what he took was 25% hematocrit, right? So what's going to happen is, let's say today is November 30. The day 29 was it, 28 was it, 27 was it. So if today I am going to calculate the reticulocytes, that reticulocyte will be these two first, right? It's 2 days, right? And not only that, it will be this, right? So this is how it's going to live, right? So 27th produce will live for 28, 28 produce will live for 29, 29 produce will live for 30. So when I'm going to calculate, I'm going to falsely calculate one more day. Because of the lifespan, I will calculate the retic count for 2 days, not just of 28th, 29th and 30th. For 2 days I am going to calculate. So I'm just doubling it. That's wrong. So what I need to know is, I need to know only this unit per day response, right? I cannot calculate 2-3 days response and give a false value. So what I do in second correction is, this is called as a correction factor or shift factor. It should be given in the question. If not given in the question, unfortunately we have to memorize. For 45 it is 1, and for every 10 point units reduction, your 0.5 will increase. That's all. Fine. 35 is 1.5, 25 is 2, and 15 it is 2.5. That's how it's going to increase. Most likely you won't have hematocrit less than 15. The patient is not going to survive, right? So what I'm going to do is, so the second correction, at the end of second correction, what we have is something called as a reticulocyte production index. Yeah, something called as an reticulocyte production index. This is what we get at the end of second correction. We call them an RPI. RPI is the basis of classifying many hemolytic anemias, especially for treatment purpose. We had a question in the NEET PG combat which is based on RPA. Right? So if you have time, just go and have a look at that. Right? We based on RPA, we divide them into hypoproliferative and hyperproliferate anemias. That's very, very important to take a decision if you're treating a patient with an hemolytic anemia. Fine. So when you have an RPI, reticulocyte production index, what happens here is, it's going to be the corrected retic count, whatever we got in the previous calculation, which was 5%, right? So my corrected retic count divided by the maturation factor. As I said, that maturation factor is the one which is given from the hematocrit value. Our patient's hematocrit, what we took an example, was 25, so maturation factor is 2. My corrected reticulocyte was 5 and divided by 2, approximately 5 divided by 2, so my reticulocyte production index is 2.5. So see from where it has come, where my original retic count was 10%. It is a very falsified value. It's a very falsified value. With the help of reticulocyte correction, I came to a realistic value of 2.5. This is an actionable value. When you have a patient in your real life, the lab will give you only retic count. I want you to correct it, do one reticulocyte production index, then it will be easier for you to come to a conclusion. That's very, very important for you to come to a conclusion. Fine. So this is practical application based. Okay. So we have laid down all our basics. So what we know is, we know about reticulocyte correction, we know about intra-extravascular hemolysis, and also we know about the basics of hemolytic anemia. Now what you're going to do is, we're just going to look at the classification based on the etiology, right? So etiology based classification was this. It's kind of a small table which might easily help me to differentiate them, fine? It is not actually etiology based classification. I should have classified that based on your intracorpuscular and extracorpuscular anemia. I can classify them as hereditary and acquired anemias as well. I can have membrane abnormalities, spherocytosis, elliptocytosis. There are lots of other diseases as well. We have something called stomatocytosis, pyropoikilocytosis. All of them are problem in the membrane only. But my main concern is this person, HS. We'll have a look at the microscopy of hereditary elliptocytosis also, but that's not my main important, right? Second thing for me is metabolism. Metabolism in sense enzyme deficiencies. When I have enzyme deficiencies, again my main concern here is G6PD deficiency. Pyruvate kinase is also required because pyruvate kinase causes a very characteristic microscopic finding. I shared that in the Telegram group. We have an image. I don't have that image now. If you have time, just go and have a look at it. We call it a prickle cell, right? We have something called a prickle cell. Prickle cell is diagnostic of an pyruvate kinase deficiency, and we'll look at G6PD deficiency soon, fine? Then I have hemoglobin abnormalities. So when I go to hemoglobin abnormalities, I divide them into two groups. I have a reduction in the amount, that's quantitative, or I have qualitative. See, whatever is written here, HbS, HbC, HbE, all of them are qualitative hemoglobin defects. The amount is normal, the function is abnormal. For example, in HbS, there will be reduced solubility. HbC will be more crystallization, right? So it's a function of abnormality. When I say amount or the quantitative abnormality, which comes your TAL, your alpha, beta, whatever TAL it is, all of them will come under that, fine? So actually, if I'm going to divide them as RBC abnormality and outside the RBC abnormality, this paroxysmal nocturnal hemoglobinuria comes in the intracorpuscular defect. Okay, this is the only acquired intracorpuscular defect. So whatever we saw, membrane defect, enzyme defect, hemoglobinopathies, all of them are inherited intracorpuscular defect. PN is the only acquired intracorpuscular defect. Apart from that, you can see many acquired conditions. AIHA for sure, red cell fragmentation syndrome with histiocytosis, infections, malaria can cause. There are lots and lots of things which can cause hemolysis, right? All of them are acquired hemolytic anemias, right? So we know a slight difference between an inherited hemolytic anemia and an acquired hemolytic anemia, okay? So now what's our goal is, we have to read the entire thing about all the hemolytic anemias, fine? Now we have discussed quite a few times about hemolytic anemias. So what I'm going to do here is, we look at each of them superficially about the pathogenesis, the inheritance. We'll have, as I said, we'll have a template. I want you to fill the template, that's all, fine? It's a very simple thing. If you go logically, it's very simple for me to fill up the template, okay? Okay, let's have a look at this. The template is going to go like this. For any hemolytic anemia, keep this template in mind. You're going to diagnose, you're going to learn via this template only, because it will give you every actionable point in the real life for diagnosis and treatment of the patient, fine? For any hemolytic anemia, I want you to remember the inheritance, because there are not too many, there are very few inheritance, so I can easily remember them, right? I want you to remember the pathogenesis. Pathogenesis includes my etiology, what is the protein defective and what are they going to cause, right? Obviously, I need the symptoms. For me, next step is the diagnosis. In diagnosis, you'll have clinical symptom. See, for every hematological disease, let it be RBC or WBC or platelets, I won't have like very specific symptoms. I do have symptoms, but it is kind of like, if I take a lymphoma leukemia, it's going to be more or less common. I'll have a lymphadenopathy, generalized, or I'll have your bleeding disorder, purpura petechiae, or a deep-seated bleeding. I do have clinical symptoms. They might not be clinching, right? So most of the hemolytic anemias, blood-related things alone, lab will have an upper hand, right? So you have your lab diagnosis. In my lab diagnosis, again, I want you to remember about CBC. In few places, CBC might help me. And like iron deficiency anemia, it's microcytic hypochromic. I won't require them for most of the hemolytic anemias, but few places, yes, it'll help me. Like thalassemia, it'll help me. It might not help me in G6PD deficiency. There are few places it'll help, few places it'll not help. Periphrasmia and any other ancillary investigations. When I say ancillary test, it could include my screening test, which is not the routine, which is individualized based on every disease, and we have investigation of choice. Once this is sorted, maybe a quick word about treatment as well. Fine. I want you to remember like this for almost every hemolytic anemia. It will be easier for me to remember in terms of this for every hemolytic anemia. Fine, got it. So let's go and have a look at one by one hemolytic anemia based on the same outlook, same outline. Fine. So first, hemolytic anemia, what you're going to look like, what was given in the table. I'm going to look for hereditary spherocytosis. That's my first hemolytic anemia, right? Okay. Just going outside. Now maybe we'll go to the other page. We'll come back to this page and look at the images whenever we want, right? To know about hereditary spherocytosis, I need to know a little bit about my normal RBC. We know that the RBC shape is biconcave disc shaped, which is due to the spectrin molecule primarily, which is there in the membrane cytoskeleton. My normal RBC doesn't have only spectrin, it has lots of other components. I'm sure you will know what the other components. Can you name any of you? Apart from spectrin, what do my RBC have in the membrane? Or in other words, the commonest mutation seen in RBC, seen in your hereditary spherocytosis, it's ankyrin mutation, right? Ankyrin is the commonest mutation seen, right? So I have spectrin, I have ankyrin, I have band 4.2, I have band 3, right? So when you take a normal RBC, this is my biconcave shape of a normal RBC. So this membrane cytoskeleton has many molecules. That's what we're going to see. We'll just zoom it and see them. It's a bipolar, so your lipid bilayer, right? It's just a lipid bilayer. So here it's normal lipid bilayer. I'm just writing lipid here for understanding. I have spectrin. Spectrin is the form of two bihelical structure. We have alpha spectrin, we have beta spectrin. This is just my normal spectrin molecule. Spectrin is not an integral component of the lipid bilayer. It will be spread in below the bilayer, right? So it's like an elastic band which is keeping the space. Someone is going to hold the elastic band and connect them to my lipid bilayer, right? The spectrin will be bound to a protein called as an ankyrin. Okay, we have ankyrin. That is going to hold the spectrin. Ankyrin will have one more protein called as band 4.2. I'll just write 4.2. It's a band 4.2. See, when I call band, it's based on the hemoglobin electrophoresis band. That's all. When I say band 4.2, it has that particular sedimentation coefficient. That's all. Band 3, particular sedimentation coefficient, right? On top of this, what I have is something called as band 3. So band 3 is the ideal person who will span my lipid bilayer, right? This I'm going to call as band 3. So all these four components are very, very essential for me for the diagnosis, for maintaining the lipid bilayer, right? As I said that it's an elastic membrane. It's been holding like this, the spectrin. So spectrin holds my lipid bilayer and someone is going to hook the lipid bilayer like this, right? So I need everything for my maintenance of my biconcave shape. Let's say that band 3 is gone, the hook is gone, so the elastic tissue cannot stay like this, it becomes spherical. In other words, any tiny damage to my RBC, it will become spherical, because spherical is the most energy efficient shape, that's all, fine? So what's going to happen here is, when any of this gets cut, this is how it happens in my RBC. My RBC is like this. If I want to go a little bit in detail, my spectrin is the person who maintains the shape by making it elastic. So spectrin alone cannot float there, right? So the person who hooks them to the membrane is these guys. So it's going to hook them like that at alternative spaces. So when the hooking part is cut, which is band 3, 4.2 or my ankyrin, my spectrin cannot maintain the shape. Or if my spectrin is lost, my spectrin cannot maintain the shape. So what's going to happen is, it will obviously become spherical. Because there's more energy efficient space, I need not stretch and hold it, right? So this I'm going to call it a vertical interaction. So these are proteins involved in the vertical interaction. Once Ames had a question that any protein involving the vertical interaction, if they are muted, you're going to have hereditary spherocytosis. And this protein here is going to be a horizontal interaction. In horizontal interaction, I have only one protein, which is spectrin, right? So horizontal interaction, if the protein is mutated, it will result in hereditary elliptocytosis. See, vertical interaction, does it include spectrin also, or it doesn't include spectrin? It will include spectrin. Great, good ascent, right? It will include spectrin for sure, right? So my vertical interaction will have spectrin, my horizontal interaction will not have spectrin, right? So all these are my horizontal interaction also has only spectrin, right? So any mutation will result in hereditary spherocytosis, right? So we have sorted the base. So now let's come to the protocol in which we are going to learn them. The first thing for me is inheritance. When I go to the inheritance of my hereditary spherocytosis, the predominant inheritance is autosomal dominant inheritance only. An exception. Exceptions are always MCQs. See, almost everything is autosomal dominant inheritance only, except one person who is your alpha spectrin mutations. If you have a mutation in the alpha spectrin, they are autosomal recessive. When you have any disease which is autosomal recessive, they present early in life and they are much more severe in manifestation, right? Rest everything is autosomal dominant only. I do have autosomal recessive inheritance also. It is an alpha spectrin defect. Alpha spectrin defect will have an autosomal recessive inheritance. Rest everything is going to be autosomal dominant only, right? So we know about this inheritance. The most common mutation of an hereditary spherocytosis is your ANKYRAN. ANKYRAN is undoubtedly the most common mutation which happens in hereditary spherocytosis, right? Okay. So when I'm going to take other thing, band 4.2, band 4.2 and band 3 or spectrin, all of them will cause the same effect. Our ultimate goal is everything becomes spherical. So my pathogenesis is very simple. The pathogenesis for hereditary spherocytosis, it becomes a spherical RBC. When it becomes spherical, I have few problems of that. The only advantage for me is it is an energy efficient state. I don't want to spend lots of energy there, right? So what's going to happen here is, sorry for the sound backlash, it's raining here, right? Fine. So what's going to happen here is, this spherical RBC will not be able to traverse the splenic sinusoids, right? I'm having a spleen sinusoid like this. Let's assume this is an afferent vessel for a spleen. The sinusoid will be like this, right? Sinusoid is in fenestrated endothelium. I'll have just tiny little bit of gaps. So when a normal biconcave RBC comes inside, you can easily escape the cords. You can easily escape the cords. That's normal biconcave, right? This is my normal. But the spherical RBCs, when they come and sit here, let's assuming it's sitting here, will they be able to escape? Because they cannot traverse them, right? The older edition of Robbins has used a superb analogy. It's saying that an elephant tried to squeeze through a circus gate. It cannot go, right? It's a very tiny one. It cannot go and squeeze it. So what happens is, this RBC, the dark shaded one, the Sphero Site, is going to stay inside the sinusoid, right? These guys will stay inside the sinusoid. When they stay in the sinusoid, obviously my littoral cell, which knows only one thing, littoral cells will engulf them. Then engulf them, it will destroy them, right? Completely it will be destroyed. So I know what's going to happen to the pathogenesis part. So if I know about the pathogenesis part, so if this is going to be, yes, I cannot help it, right? So if it's going to engulf, so the way of hemolysis happening here is extravascular hemolysis or intravascular hemolysis. Just TC99, technetium 99, good name. Extravascular, intravascular hemolysis. A good lesson, it will cause extravascular hemolysis, right? It's going to cause an extravascular hemolysis, fine. So the patient will the patient have hematuria? A patient with hereditary spherocytosis? They won't have hematuria. The only finding I'll see is splenomegaly, right? We look at the clinical symptoms soon. I know the pathogenesis, I know the etiology, I know the inheritance. The next thing I'm going to tick here is my your clinical features. So I'm just going to take the clinical features next. See, this is a patient with an autosomal dominant inheritance. You must have definitely read this. What do you think will be the age of presentation for any patient with autosomal dominant inheritance? elderly or young? I'll give you a clue, ADPKD. Elderly or young? Perfect. It will be elderly only, right? Because almost every autosomal dominant inheritance, I have one allele which is completely normal, only one is mutated. So I can have a decent time for for few years at least, right? So first thing, they will be adults. Except one type of mutation, the alpha spectrin. Alpha spectrin alone will present early in life, right? IK, they will present generally in an adult, fine? Okay. Second thing, again the same concept, it's autosomal dominant, one allele is completely normal. So the amount of hemolysis will be severe or less severe? It will be less severe, right? A less severe hemolysis. Okay, I'm gonna have a less severe hemolysis there. So when I have a less severe hemolysis, let's assume the patient has an hemoglobin approximately of 10 or 11. The normal being 14, 15, 10 or 11 is definitely hemolysis. Do you think the patient will present to us? 10 or 11 hemoglobin. Will the patient present to me? The patient will not present to me, right? The patient is not going to present to me. So what's going to happen is I'm having a less severe hemolysis, the patient don't present to me. So it's unnoticed chronic hemolysis. So can I say that the amount of bilirubin stored in the patient will keep on increasing over the period of time? For a long, maybe years together, it will. When it keeps on loading bilirubin years together, one fine day, they might present as an gallstone. What type of gallstone do you think the patient will have? Pigmented gallstone or an cholesterol stones? Patient will have an perfect. The patient will have a pigmented gallstone, right? Patient will have an pigmented gallstones. Perfect. Okay. So this is a triad. I have adults presenting with a pigmented gallstone. The most important, the third one. It's extravascular hemolysis. So obviously I'll have an palpable spleen, which is in splenomegaly. Fine. So I'll have an adult having a splenomegaly and less severe hemolysis. This is a triad I am going to suspect for an hereditary spherocytosis. Fine. So I know a little bit about the patient profile for hereditary spherocytosis. Fine. So now next is my lab diagnosis. When I go to the lab diagnosis, what is important for me in the lab diagnosis? I need CBC findings, I need peripheral smear, I need few ancillary tests as well. First, I'm going to look at the Sphero Site. This is the same protocol I'm going to use it for almost every hemolytic anemia, right? Then CBC, I won't have alteration in my MCV, that will be completely normal. But when you look at this as biconcave shaped RBC, compared to that, the RBC has become spherical. Can I say that when I'm going to elastically pull the RBC and become spherical like this, the volume per RBC is reduced? Is it reduced or it is elevated or it's normal? It is reduced, right? I can say comfortably that it is reduced, yes? So as in reduced size of the RBC, the volume is less, not the mean corpuscular volume, the per cell volume. This volume is bit less. When the volume is less, do you think there is any alteration in the production of hemoglobin in hereditary spherocytosis? The hemoglobin production is completely normal. Is there any alteration? No, right? There's no alteration of hemoglobin production, but the volume is bit less. So can I say that it will become more concentrated? It has to, right? That's my only finding I can see in CBC. Elevated mean corpuscular hemoglobin concentration. You can remember this forever. This is like almost only hemolytic anemia where the hemoglobin concentration will be elevated. I won't have any other hemolytic anemia where MCHC will be elevated. This is like a point, this is like a clue for me. See this in CBC, most likely spherocytic anemia, fine? Second, I come to peripheral smear. So in peripheral smear, I need to pick up spherocytes. This is a normal RBC. When I look at a normal RBC, my hemoglobin will be in the periphery. It cannot be in the center because my center is getting compressed like this, right? So it's in the periphery. When I look under the microscope, for my microscope, I look from the top. So how it looks is, it looks like a round RBC with lots of hemoglobin in the periphery. The center part is pale. The central 1/3 pallor is completely normal. The 1/3 central will be pale. Okay. It has to be pale, it will be pale. This is in a normal RBC. Now let's look at Sphero Site. When I'm looking at Sphero Site, there is no biconcave shape. So am I right in saying that it will be uniformly like this? So under a microscope also it will be uniform. The central pillar will be gone. So to identify a spherocyte, I have 3 pointers. All 3 just now we saw. I said volume will be a bit smaller. So it will be a smaller RBC. My MCHC is elevated. So it will be obviously a darker RBC. Third one, no central pallor. Right? I have no central pallor. So all these 3 are pointers to diagnose an Sphero Site. This is how and every Sphero Site is going to look. A smaller RBC, a darker RBC, no central pallor. Sorry, it is getting cut off. I am just moved it. Fine. So that's how I'm going to see them. Let's see, confirm in my real-time peripheral smear whether it's correct or not. Right? I just go and have a look at the peripheral smear. Okay. I hope I have the image. Yeah, look at this. This RBC, can I call it normal? Are you having a central pillar there? Or you're not having a central pillar there? The RBC which you marked. Okay, it's not seen. Maybe I'll push a little bit upwards. Is it normal or abnormal? This RBC is definitely normal, right? So there is a central pillar. This is a completely normal RBC. Got it? So when I compare that RBC to these RBCs, are they smaller? Yes, they are smaller. No central pillar. Undoubtedly it is darker. So this, in this image, all these are Sphero Site, right? Okay. Apologies for the rain. It's raining heavily, fine. So all these are Sphero Sites forming, fine. I have Sphero Sites, I have central RBC. So I can easily pick up a spherocytic RBC. So for me, the spherocytic RBC is not the only goal. Because with this alone, I cannot say it is an hereditary spherocytosis. I have multiple other causes of spherocytic anemia, fine. I'll go back to the other image, other slide, whatever we wrote it. So here, sorry, yeah. So this is where we stop. So what I'm going to have is, I know that with the help of it, I can call it an spherocytic anemia. Yes, technician, Chennai. Right. It's very rare to have rain here. If it rains, it's going to spoil the entire city. Fine. Okay. So it's a spherocytic anemia here. Fine. So when I have spherocytic anemia, I cannot call it hereditary spherocytosis because I have many other differential diagnoses for spherocytic anemia. For example, the commonest cause of spherocytic anemia is autoimmune hemolytic anemia. Fine. When I have spherocytic anemia, the most common cause is autoimmune hemolytic anemia. That's also a question. See, it's an acquired anemia. Definitely acquired anemia will be much more common than spherocytic anemia, hereditary spherocytosis, right? Not only that, I have multiple other things. G6PD deficiency can cause spherocytes. Your sickle cell anemia can have spherocytes. Thalassemia can have spherocytes. So like spherocytes is an evidence of cell damage. Anything can have spherocytes. So I cannot diagnose just with spherocyte, it is spherocytic anemia. So what do I do next? So what do I do next is, my protocol in a real life is different from what I teach you in an exam, right? So I'll tell you both. I actually don't want the test of osmotic fragility. I'll tell you why I don't want, but unfortunately we have to read that. That's what your textbook says, fine? So when I have a spherocytic anemia, the next step we do, that came in an exam once, the next step for any spherocytic anemia is, I have to do an Coombs test. You have to do a Coombs test. Because Coombs test, I have to rule out one person. Which disease do you think which helps in diagnosing Coombs test? Sorry, Coombs test is useful for diagnosis of which disease? Which disease? I have to rule the most common cause. It's going to be perfect. It's going to be autoimmune hemolytic anemia, right? So it helps to rule out autoimmune hemolytic anemia. Fine. So once Coombs is negative, if it is spherocytic anemia, my Coombs test will be negative. Fine. So if it is Coombs test negative, I have two way of approach, one for textbook and one for real life. In a real life, I don't want you to do osmotic fragility test. It is not required at all. What I'm going to do here is, in a real life, if you want, go for flow cytometry directly. Because flow cytometry is the investigation of choice that will help me to diagnose. Hi Aman. That will help me easily to diagnose my spherocytic anemias. Fine. If for a textbookish, I need a test called as an osmotic fragility test. So you look at osmotic fragility test and I'll say that why it is not required. Yeah, OFT, and we have something called an incubated osmotic fragility test. Both of them is not required for management of a patient. I go for flow cytometry directly if Coombs is negative. If I want to prove this hereditary spherocytosis, fine. So we look at osmotic fragility test. You yourself will say that it's a test which is not required for me, fine. So for an osmotic fragility test, the concept is simple osmosis. That's all. Normal osmosis where you have an hypotonic solution. The fluid moves from one compartment to the other. That's all. There are few prerequisites. What do you think is the anticoagulant useful for osmotic fragility test? That's an MCQ which came once. I cannot do that in a routine EDTA coagulated blood. I need a special anticoagulant. What do you think is the anticoagulant useful for osmotic fragility test? It is great. It is heparin, right? Hi, Devapriya, right? This is heparin. I have to do it only in an heparin blood, and I need lot of blood here. 5 to 10 ml is what the requirement is. I cannot do it at 2 ml of blood because I need to replicate the test multiple tubes, right? I'll show you an image of osmotic fragility test. This is how an osmotic fragility test is done, right? See here, it's written. It will be written like this. The percentage of saline here, right? I need at least 10 tubes to replicate the test. I need lots of RBCs, lots of blood required for me, right? That's how I do an osmotic fragility test. So what I do in an osmotic fragility test is simple. I'll take 0.9 normal saline, that's isotonic. I reduce it 0.8, 0.7, 0.6, 0.5. Each tube will have that specified amount of saline which is written on top. So I'm going to see whether hemolysis is happening or not. Based on the amount of hemolysis happening, we put this entire tube into a spectrometry. You must have seen in your biochemistry machine, the spectrometry. You put that, it'll give me a value. It'll tell you the amount of lysis happening. That amount of lysis, I'll plot in the form of a graph. Okay, we'll look at the interpretation of graph very soon. This is what I'm going to do in an osmotic fragility test. It'll be plotted in the form of graph. Then I can easily say that it's normal or hereditary spherocytosis. Fine. I'm just going back to the previous one for me. Okay. So I'm going to do this in an heparin anticoagulated blood. We are going to do an osmotic fragility test. So I'm just going to tell you the normal concept. Let's say there's a normal RBC. When you put in an hypotonic saline, when you're going to put in an hypotonic saline, what's going to happen is the water or the saline enters inside. Once saline enters inside, my RBC becomes bigger. After some time, my RBC is going to become more bigger and it will burst or it will undergo hemolysis. Got this? This is how normally it happens. In other words, when it have an hereditary spherocytosis, it's already round. I don't have enough space, right? Because we just now saw that they are smaller RBCs. I don't have enough space and they are rigid as well, right? So they will swell and they will burst. So if this is true, listen carefully and answer. The RBCs of hereditary spherocytosis are osmotically more stable or osmotically more fragile. They burst earlier, right? More stable or fragile? Great, they are more fragile, right? So I'm just saying they are more fragile, that's all, because they can burst earlier. That's very important for me. One more thing here is, whatever I am saying, the fragility is based on which cell? Sphero Site, right? It's based on Sphero Site. So my interpretation is nothing extraordinary. I saw Sphero Site first of all. I am doing an osmotic fragility test. I am again telling I am seeing Sphero Site. Because when you look at the protocol, this is what it started with, right? I saw spherocytic anemia. Why do I need one more test to say that it's Sphero Site again present there? That's the reason I said that osmotic fragility test is not required for a real-time diagnosis of a patient. But for an MCQ, keep this in mind. It might be required for an osmotic fragility test. We have two types. It's actually a screening test. Osmotic fragility test, the best screening test is incubated on osmotic fragility test. When I say incubated, I don't do anything. I just take the patient's blood, keep it for a day or so, don't do anything, and I do the osmotic fragility test after a day. That's all. That's an incubated osmotic fragility test, right? So this might be required from a theoretical point of view. From a practical point of view, I don't want, because my interpretation is still Sphero Sites. That's all. Fine. So as I said, it will be 10 tubes and I'm going to replicate it 10 times. I'll plot a graph. And look at the graph. This is how the graph of osmotic fragility test will look. This is from a book called Daisy and Lewis. That's the book for standard for all laboratory procedures. Fine. Look at this. In the y-axis, I have percentage of hemolysis. In the x-axis, I have my amount of hypotonic saline. See, this is 0. It always starts from 0.1, 0.2, 0.3, 0.4, 0.5, 0.6, maybe here 0.9 isotonicity. Isotonicity, it will not rupture for sure. So a normal person, you and me, my hemolysis starts around 0.4 to 0.5. That's where my hemolysis starts. Which means in 0.7, there is no movement. Even there's movement, it's not undergoing lysis. 0.6, no lysis. It can accommodate more volume. 0.5, maybe lysis starts. And the lysis will almost be complete around 0.2 or 3. Fine. It will complete around 0.2 or 0.3. Fine. So in other words, in a spherocytosis who is osmotically fragile, 0.9, there is no movement inside. 0.7 itself it will start, which means with little saline going inside the RBC, they're going to burst. In other words, they are osmotically more fragile, right? So hemolysis starts around 0.7 and be completed around 0.4 or 0.5, right? They are more fragile, so the curve shifts to the right. The curve shifts here. Again, this shifting of curve is totally subjective. Why I wanted you to understand this is, when I say a curve shift towards one side, if I by chance, by mistake, let's assume I am plotting a curve like this, 0 here, 0.1 here and 0.9 here. If I plot the curve in the reverse, the normal will be still here, and in hereditary spherocytosis it becomes to this side, right? That's very important for me. It might totally differ, the shifting of the curve might totally differ if the graph is plotted in the reverse direction. Why this is important is, Winthrop's hematology is the standard book for hematology. Winthrop's plots this curve like this. I don't know why they plot like that. Unfortunately, it is plotted in the reverse direction. So if anything comes on that aspect, you should be able to know that. Fine. Okay, got it? Fine. So we know a little bit about my osmotic fragility test. Fine. So as I said that for a real life scenario, I might not require an osmotic fragility test. Without that itself, I'll be able to diagnose the patient. So I know a screening test, our outlet of it is done. I know the patient inheritance, your mutation, pathogenesis, clinical features, lab diagnosis, confirmation. Confirmation is by flow cytometry. Investigation of choice undoubtedly is a flow cytometry called as EMA flow cytometry. So we do a test called eosin 5 maleimide. It's the same flow cytometry, it's just EMA, that's all. EMA is eosin 5 maleimide. Okay, it's an eosin 5 maleimide based flow cytometry. I can do your mutation analysis also, but unfortunately when I do a mutation analysis, it is going to be expensive because I have to look for ankyrin, spectrin, band 4.2, band 3, 4 genes, multiple mutations. I'm not going to spend time on that and money on that, so I do eosin 5 maleimide flow cytometry. So this EMA or this dye is going to bind to band 3. It's a normal dye which binds to band 3. Let's assume this is a normal RBC. If everything is normal, the band 3 is the topmost one. If you remember, the dye can easily bind to the band 3. When it binds to the band 3, I'll have positive color on flow cytometry. Fine. Okay. Hope we'll learn more together. Okay, fine. So it will bind to the top of the band 3, and I'm definitely know that it is a normal person, right? Let's assume the same thing is a Sphero Site. Okay, it's just a Sphero Site. When you have a Sphero Site, let's imagine like this. We have 4 floors here. The bottom one is my spectrin, the top floor is band 3. If the spectrin is gone or the ground floor is gone, can I say that the top floor will collapse? It will collapse. Yes. If my ankyrin is gone, will the top floor collapse? It will, right? Band 3 gone, it will collapse. Band 4.2 gone, it will collapse. So all these are vertical interaction. That's why the starting point is important for me, right? If possible, I'll go to the starting point. This is where we started. These are the 4 vertical interactions for me. If anything is gone, everything will get collapsed. When everything gets collapsed, what happens is the staining pattern will reduce a lot. Fine. So in a spherocytic anemia, whatever may be the mutation, the binding of band 3 will get altered if any one of the above is getting mutated, right? So here the band 3 can't bind When band 3 can't bind, so to the band 3 my EMA can't bind, sorry, because any mutations there, EMA can't bind. So even if EMA can't bind, I'm going to have a negative staining here. Fine. So a positive staining and I have a negative staining, so I can easily identify what's happening in my flow cytometry. So flow cytometry is the investigation of choice. With that, I diagnose the patient. Fine. I know the diagnosis. Diagnosis is simple for me here. So obviously next step is treatment. I'm not going to give you details about treatment. The only thing I will tell you about details about treatment is I can do a splenectomy. Okay. The medicine hematologist will tell you more about the when to do a splenectomy and what are the parameters I'm going to keep for a splenectomy. If at all the anemia is troubling for the patient, you can remove the spleen, you can do a splenectomy. Fine. So that's one question came once in exam. After doing splenectomy, and a patient has undergone splenectomy, after splenectomy, will the amount of Sphero sites persist or it will disappear? The Sphero sites in the peripheral smear, will they persist or disappear? Perfect, they will persist, right? So post splenectomy, I'm removing the spleen. Post splenectomy, the Sphero sites are going to persist. They don't disappear, they persist. Because I'm not removing or changing the pathogenesis, I'm just removing the site of destruction. Extravascular hemolysis, I'm just removing the site of destruction. That's what is going to happen here. Fine. So we know about little bit about hereditary spherocytosis. This is the first hemolytic anemia we wanted to learn. We'll try to kind of look at the complications as well. I have 2 complications for every hemolytic anemia that will be seen here also. One of the complication here is this complication can be applicable for every hemolytic anemia from head to foot. You have 2 complications. One is my aplastic crisis. The other is hemolytic crisis. Okay. So when I have an aplastic crisis, as the name says, it's aplasia. There is no functioning of the bone marrow in respect to my erythroid lineage. That's why I call it an aplastic crisis, right? So when I say aplastic crisis, this is due to a particular infection. I'm sure you must have heard about them. Parvovirus B19. Hemolytic crisis, again as the name says that there is more hemolysis than expected. It can be due to any infection, right? It can be due to an Epstein-Barr virus, which can cause a splenomegaly. It can be due to malaria, which can also cause a splenomegaly, right? Any hemolysis, any disease which can cause splenomegaly, the amount of lysis is going to increase. So I'm going to call it an hemolytic crisis, right? So when I have aplastic versus hemolytic crisis, the clinical presentations for the both is same. There will be a drastic drop in hemoglobin. I'll give you a scenario. You are having patients in your ward. So admitted patient of an hereditary spherocytosis. Everything is going perfectly normal. Yesterday you did a routine hemoglobin value. My hemoglobin was 10 gram percentage. And today you repeat the hemoglobin value because you want to discharge the patient. The hemoglobin is 6 gram percentage. In a single day, I have lost 4 grams of hemoglobin. Will that happen in hereditary spherocytosis? Because you guys only said that it is a very very low-grade hemolytic anemia, right? It will not happen in hereditary spherocytosis, right? So that time I have to suspect these 2 crises. So I have to confirm them. How do I confirm it is aplastic or hemolytic? I don't want PCR. Let's say I'm running short on funds. The patient is not able to pay for a PCR. Because virus infection, PCR will definitely give me a clue, right? So I don't want to have PCR technique or there's an economical problem. So what is a simple test we can do to differentiate these both? It's one very simple test. That's what is the basis of my disease as well. One is aplasia. So what I'm going to do is I'll order a simple retic count. Okay, when you do a retic count, what do you think will happen in aplastic crisis? The amount of reticulocyte, that's aplasia, will be reduced or elevated in an aplastic crisis. Any aplastic crisis, when I'm not having the normal functioning of RBCs, this not being produced, obviously the retic count will drastically drop. It will be around 0.5. The normal is 1 to 1.5. Here it is hemolysis. more is the hemolysis, more will be the response by the bone marrow, and I'm going to have more increased reticulocyte count, right? So that's what will happen in your hemolytic race, right? So with the help of simple reticulocyte count, I can differentiate an aplastic races versus an hemolytic race, right? Great. Okay. So this can be seen in any hemolytic anemia. I can use these simple tests of reticulocyte count to diagnose what type of hemolytic crisis it is, right? So we are done with my hereditary spherocytosis. Perfect. Okay. So now we'll have a quick look about the next disease. Okay, that's my G6PD deficiency. Okay. So when we want to read about G6PD deficiency, I need to know again normal energy consumption of an RBC. How normally a glucose is being taken care of, metabolized by an RBC. The same thing we did for hereditary spherocytosis. We laid on a normal base framework, right? So what's going to happen here is, in a patient with a G6PD deficiency, normally when I have a molecule of glucose, this goes into an RBC. So RBC has two pathways. One is my glycolytic pathway. The main purpose of glycolytic pathway is to give ATP. Can RBC have this? It's just going to give ATP, that's all. For me, ATP alone is not enough. I have a protective pathway. That protective pathway is HMP pathway, hexose monophosphate pathway. What do you think is the outcome of HMP pathway? HMP pathway does not give me ATP. It gives one more molecule, which is your NADPH, right? It gives my NADPH. So with the help of HMP pathway, the outcome here is NADPH. NADPH will not give me energy. It's a protective pathway. Okay. So whenever a molecule of glucose is being consumed by my RBC, it will use them for both of them because I need both. Energy is one place. I need protection also. Why this protection is very important for me is, RBCs are nucleate or anucleate? It's a very simple question. Is it nucleated cell or anucleated cell? It is an anucleated cell, right? If it's an anucleated cell, can my RBC synthesize new enzymes? It cannot synthesize new enzymes, right? It will not be able to synthesize new enzymes. In other words, let's say that I am having a cell, a random cell. I'm getting exposed to free radicals. I scavenge the free radical with the help of enzymes. Then my other cell produces new enzymes to tackle new free radicals. But RBC cannot do that. They cannot synthesize new enzymes. So which means they are born with X amount of enzymes. The same X amount of enzymes they should keep for next 120 days. That's my problem here. So I need to recycle them. I cannot waste them. I need to recycle them because my RBC cannot synthesize anything. That's where my NADPH comes in place, right? And my G6PD, glucose 6-phosphate dehydrogenase, is an important component of my hexose monophosphate pathway, fine? Let's see what's going to happen. Again, we are just looking at the normal. Once we know normal, abnormality is very, very simple for me, right? So when I have a G6PD, the enzyme, G6PD is going to convert, I'm sure you know the biochemical change. I think it converts glucose 6-phosphate to 6-phosphonogluconate, something of that sort. You have glucose 6-phosphate thing to 6-phosphonoglucate. I'm not sure about that. You will know more about that, right? So the byproduct, what it produces is, it produces NADPH. Okay, right? It produces NADPH. This NADPH is very, very important for me for recycling. So what this NADPH, the excess hydrogen present here will do is, it will be useful by my glutathione reductase, right? My glutathione reductase will use it. So glutathione reductase is not the free radical scavenger. Glutathione peroxidase is a free radical scavenger, right? So this glutathione reductase will convert my GSSG to an, again it's an oxidase variant of glutathione to an reduced glutathione, because this guy can reduce in free radical. So here I'll have glutathione peroxidase. Okay. I'll have glutathione peroxidase. This is my free radical scavenger. Okay, this is a free radical scavenger. That's an enzyme which I'm looking for. So the glutathione will take the extra birth of a free electron, right? This will make a free radical or a reactive oxygen species non-toxic. It's going to convert to non-toxic. To be specific, it will convert my hydrogen peroxide to water. That's what it actually does. It will convert my hydrogen peroxide to water. This is what it does, fine. And this is completely normal. I'll just zoom out a little bit. This is what is going to happen in a normal place. Glucose phosphate gives me NADPH. That's useful for recycling of glutathione peroxide reductase mechanism to make sure my reactive oxygen species becomes a non-toxic material. Let's assume, look at the pathogenesis. I'm having a patient with no G6PD. Will NADPH produce? No. Will this recycling happen? No. So first time I'll be able to reduce reactive oxygen species, but I cannot recycle the person. So when I cannot recycle the person, there'll be reduced recycling happening about the glutathione oxidase and the reduced glutathione. When that happens, my ultimate problem is I'm going to have more free radical induced damage. I'm going to have more amount of reactive oxygen species induced damage. So that's my pathogenesis. I'm going to have more free radical induced damage to my RBCs. That's my ultimate problem which is going to happen in this patient, fine. So we know about entire thing about my G6PD deficiency. So the final problem is reactive oxygen species induced damage to the RBCs, right? So if I know this, I will also be able to easily tell about what will happen to the RBCs, because we know free radicals. Free radicals kills a cell in the same way. Almost always it will be in the same way only, fine. So what happen in the same way, like you have lipid peroxidation, you have protein denaturation, you have DNA damage, right? These are the three ways by which free radical is going to destroy a cell. When I take RBC, do you think DNA damage will happen, or is it important for me? It is not important for me, right? It's not at all important for me. So the only thing required for me in an RBC is a free radical induced damage, where I'm going to have two main things. One is my lipid peroxidation. This can damage my RBC membrane because it's lipid at the end of the day. The other person where my free radical can cause a problem for me is my protein denaturation. I don't bother about my DNA damage because RBCs don't have a nucleus, they don't have a DNA, fine. These are only two things going to happen. So it's lipid peroxidation of the cell membrane or the RBC's membrane. So am I right in saying that when I am going to consider the free radicals, the amount of free radicals is not always constant, it will fluctuate for sure, right? So which, in other words, it fluctuates in the sense, let's say that I'm going to give you two scenarios. I can have lots of free radicals at a given point of time. At the same time, I can have very little free radicals. Both of them are possible, obviously possible. When I have lots of free radicals, can the free radical go and damage the membrane and rupture the cell? Is that possible? It will rupture the cell, can it? It can, right? So when it ruptures the cell, will it cause intravascular hemolysis or extravascular hemolysis? It's going to rupture inside the circulation because free radical is going to be there inside the circulation. It will cause, perfect, it will cause good SN. It will cause intravascular hemolysis, right? So a normal RBC, when it's having an excess amount of free radical induced damage, it can easily rupture my cell. I'm just putting in dotted lines for us to understand this is rupture. So which means it can cause an intravascular hemolysis. We look at the other scenario as well. I'm having slight elevation of free radicals. So I have a biconcave shaped RBC. It's just hitting the membrane like this slightly. So it will become spherical. A less severe damage obviously make it a Sphero Site. A Sphero Site will undergo intravascular hemolysis or extravascular hemolysis. That also we saw just above. It's going to cause an extravascular hemolysis, right? Cause an extravascular hemolysis for me, fine. So now what's going to happen to my RBCs inside the blood vessel and outside the blood vessel, right? Okay. So it's not just, I'm going to have protein denaturation also. When I'm going to consider protein denaturation, my main concern for protein denaturation is your hemoglobin. Hemoglobin is a predominant protein inside my RBC that will undergo denaturation. My hemoglobin is going to get denatured. When any protein gets denatured, it will precipitate. When anything precipitates, it comes to the close to my cell membrane, right? And this denatured globin cannot be picked up on a routine Leishman stain. I need a supravital stain that's called a new methylene blue. Fine. And I have hemoglobin denaturation. I'm going to have two appearances. One is my Leishman stain, as I said, which can't be seen. Other is my new methylene blue stain or my supravital stain. In a supravital stain, I can easily pick them as a tiny little dot, right? Which will be close to the membrane only, because denatured or any precipitate will obviously settle down in the bottom. It goes close to the membrane. Fine. So when it goes close to the membrane, I call this finding as an Heinz body, right? I know that it's an Heinz body. The same thing in a Leishman stain, it is not seen. That's all, right? It's not seen, right? You can't see a denatured protein in a Leishman stain, right? Maybe it becomes like a John Cena. Okay, sorry for the PG. Fine. So it's not seen here. It is not seen. How it is going to look here for me is it's going to look like an unstained part. So an unstained part of the RBC coagulum is going to become like this. So it's the same RBC, it is not getting stained. The unstained part of RBC coagulum will look like an bite cell for me. Again, that is diagnostic. This is some place where Robbins has given a outdated information. I will not say it's a wrong information. It was the old way of understanding. In Robbins, it will be given that Heinz bodies will be plucked by my splenic macrophages. That was an older terminology, older way of thought process. It's been updated for almost 10-12 years. So look at the new thing. Bite cell is due to the unstained RBC coagulum, which is not seen in a Leishman stain. I'll have bite cell. So I know the pathogenesis. So ultimately, every damage is due to reactive oxygen species, which means post-infection, will there be more damage? It has to be, right? In other words, I'll have trigger-based hemolysis, right? You will have a trigger or you'll have episodes of hemolysis. The trigger for the hemolysis, the first trigger for me is infections. That's the most common trigger for hemolysis. Second for me is your drugs, especially two group of drugs I want you to remember. One is primaquine, other one is dapsone. Primaquine, dapsone, both of them can trigger hemolysis, right? Your anti-malarial drug and your anti-lepra drug. And so before giving primaquine and dapsone, if you're going to give for a longer duration, just do a G6PD testing first, a screening test at least, if you are in a area where the incidence is very common. Fine. The third one is favavins. All these are triggers for my hemolysis. So post this trigger, automatically the lysis will start happening. It's a very acute event. When the new reticulocyte comes, lysis will reduce because they have a little bit good supply of glucose 6-phosphate, a little bit good supply of my glutathiones, and automatically it reduces, right? It's just an episode of hemolysis, automatically it'll come down. So the only treatment what I'm going to give is supportive treatment during the crisis. Otherwise I don't want anything here, right? So I know about the trigger, I know about the pathogenesis. Now I have to come to the diagnosis. Diagnosis goes in the same thing. CBZ, apart from the anemia, I don't have any diagnostic clue. There will be no alteration in the MCV or MCH. Nothing will happen. I'll just have anemia. That's all. It's a normocytic anemia. Second, peripheral smear. 2 staining in peripheral smear. Leishman. Supravital. In Leishman staining, I have 2 findings here. One is Sphero Site. I will see Sphero Site here. The other person I'm going to see is bite cell. If the bite cell is incomplete, I call something a blister cell. Bite will be like this. It's gone completely. Blister, it's like, see, both are unstained part, right? So blister cell, just for understanding. So the blister cell will be like this. The only thing I can see in a blister cell is you can see the tiny membrane which is covering it, right? When it covers it, I call it a blister cell. When it's completely gone, I'm going to call it a bite cell. Fine. So in a supravital stain, what I can see is, again, two findings: increase in my reticulocyte count. Now obviously the other finding what I'm going to see is, you'll have your Heinz bodies, thought blocks, sorry. And you're going to have an Heinz body. Fine. Okay. So I'm going to see these findings in my supravital stain and in my Leishman stain. Okay. So we'll look at the microscopy here. You must have seen bite cell plenty of times, right? What cell is this? If you can say, we didn't discuss about this, but still I'm sure you will know that. What cell is this? This cell. What is the cell you're seeing here? It's not a bite cell. It's not Sphero Site. It is perfect. I think you meant elliptocyte, isn't right? It's an elliptocyte, right? It's an elliptical cell. It's an elliptocyte. Fine. This will be seen in hereditary elliptocytosis. Elliptocytosis, generally, it is not like an very severe anemia. It's an incidental finding. I screen the patient for something else, and this comes out. It's a very innocuous, low-grade anemia. Fine. Okay. And these are my classical findings here. These are your bite cells, right? So when I see bite cells, I'm going to think of a G6PD deficiency. There are 3 bite cells in this image, right? Below one as well, and there are multiple bite cells in the image, right? Okay. So I know about the peripheral smear finding of G6PD deficiency. So next, what I'm going to do is, we have to understand a little bit about your the screening test and my investigation of choice. So ancillary test, right? I do have 2 screening tests. We look at one screening test now. I discussed about one more screening test in the Unacademy free special classes. If you have time, there'll be something called Disease 360 for G6PD. Go and see, have a look, especially if you're a second year or a postgraduate. There'll be an in-depth understanding about the disease. Fine. So I have 2 tests here. One is my methemoglobin reduction test. Other screening test is an fluorescence spot test. We won't look at fluorescence spot test now. We'll just look at the methemoglobin reduction test alone. And I do have an investigation of choice. It's simple investigation. It's an enzyme analysis. It's an enzyme deficiency. Obviously, the investigation of choice has to be an enzyme analysis, right? That's simple. Let's have a look at about the methemoglobin reduction test. It's a very simple procedure. So what I do is, I reduce the normal, I take a patient's blood, I add to the patient's blood sodium nitrite. The same simple principle what we did in Sally's hemoglobinometer, right? We didn't add sodium nitrite, we created sodium nitrite there, right? So what I'm going to do is, when you add sodium nitrite, it will convert hemoglobin to methemoglobin, right? Just see the first line alone. So once it converts hemoglobin to methemoglobin, it will have a color of brown color. This process is reversible. It will come back to normal if I have the hydrogen or an NADPH. So after it turns brown in color, I'm going to add methylene blue to it. Once you add methylene blue, it will stimulate pentose phosphate pathway. If my G6PD is completely normal, it will reduce methemoglobin back to normal hemoglobin, right? So in a normal patient where G6PD is completely normal, I'll produce an NADPH and I'll come back to normal hemoglobin. In a patient with a G6PD deficiency, the methemoglobin persists because there is no NADPH. It will not come because my hexose monophosphate pathway is defective here. It's not going to come back. This is a screening test for my G6PD deficiency. Fine. I'm going to show you 2 images here. You're going to tell me which is normal and which is deficient here. Fine. I have 2 images here. Let's mark it 1 and 2. Tell me which is normal here. Which is normal? The normal thing is, patient 1 is normal. The image, sorry, this is 1. I'm sorry if it's high. Right? This is normal. This is, I'm having persistent methemoglobin, the brown color. This is abnormal. This patient is having a defect in the hexose monophosphate pathway, most likely a G6PD deficiency, right? This patient is normal, this is abnormal, right? That's what I do in my methemoglobin detection test. Okay, correct. Fine. So these are few things regarding your G6PD deficiency. Sorry, fine. We'll come back to it. So I know about the screening test. I know the diagnostic test of G6PD deficiency as well. Okay. So we'll have a look at one more thing before we call it off a day. One more hemolytic anemia here. Let's look at PNH, because PNH is one which I wanted to discuss for a longer time. Right? When you look at paroxysomal nocturnal hemoglobinuria, again we're going to have the same protocol. We look at normal. I need to know normal. Once I know normal, I can know the inheritance, know the basic etiopathogenesis, and we can extrapolate to the patient and diagnostic protocol, right? So when I say PNH, the normal background basics for PNH is, when any person sleeps, will that be a change in respiratory pattern? Obviously there will be a change in respiratory pattern, right? So what happens is, I will have a reversible acidosis. When there is going to be an acidosis, there will be reversible respiratory acidosis, right? So this acidic environment will activate complement. So when complements get activated, again during a sleep, this person will have your C5 to 9, your MAC complex. See, complement is a plasma protein. So obviously the plasma protein complement in the circulation will get activated. So this, when the MAC complex forms, can they lyse RBC? They can lyse RBC, WBC as well as platelets, right? So if this is true, almost everyone, when we sleep, we should end up in having a hemolytic anemia. Yes or no? Yes, hemolysis should have happened, but it is not happening for me. So I wanted to understand why it is not happening for me. The reason why it's not happening for me is, I have few molecules in my RBC which is going to protect from my MAC complex, or which is going to protect my hemolysis, right? So it's normally happening. So in my RBCs, we have two molecules, CD55 and CD59. 55 is called as TAF, a decay accelerating factor. That's one. CD59, we have something called as an MIRL. MIRL stands for membrane inhibitor of reactive lysis. This guy will, just for understanding, destroys MAC complex, and this guy will destroy your C3 convertase, because C3 is to C3A is one of the important step in my complement activation, right? This guy destroys C3 convertase, fine. So these are proteins on the surface of RBC. They can't just like that float. I need someone to hold the protein, right? So let's assume this is a normal RBC. These two are the proteins. I put two lines for my CD55 and CD59. Both of them will be anchored to the RBC with the help of a protein called as GPI, glycophosphatidylainositol. So this is my CD55, this is my CD59. In other words, when I sleep, complement will be activated. So it's a plasma protein, and in the plasma is where in the blood is where I have my complement as well as my RBC. So once it tries to activate complement, RBC is fine in lakhs and lakhs quantities per ml of blood, right? So this 55 and 51, everyone gets activated. Stop it. So it will make sure it's going to protect my entire blood during sleep from a free radical or complement induced lysis, right? So the problem in PNH, this guy is going to protect from complement induced lysis. Okay. Fine. So this is normal, right? So what's going to happen in PNH is, PNH is not an inherited disorder. It's the only acquired RBC disorder, right? Intracorpuscular disorder, right? So you have PNH. In PNH, there's not a defect in 55-59. There's a defect in, or there's a mutation. It's an acquired mutation, not a congenital mutation. Mutation in PIGA gene. This gene codes for GPI. So in PNH, my main problem is in the GPI. The GPI is abnormal. So when my GPI is abnormal, obviously I'm going to have problem. I cannot stick my CD55 and 59, right? So when I know normal, when I know the problem, I can easily extrapolate the pathogenesis. So what happens is, each time when the patient sleeps, the activation happens, I'm going to have complement mediated lysis of, it's just RBC or all three of them. It has to be all three of them, right? RBC, WBC and platelets. All three of them will undergo lysis, right? So this will lyse my RBC, WBC and platelets. It's going to lyse all three of them, right? So what I'm going to have is, I'm going to end up in something called as an pancytopenia. And I'll have pancytopenia here. All three of them will undergo lysis. So this lysis is intravascular or extravascular? It's intravascular hemolysis, right? So obviously when the patient wakes up next day morning, during sleep lysis happen, next day morning the patient is going to have hematuria. Paroxysmal nocturnal hemoglobinuria presenting as an early morning hematuria, diagnostic of PNH. It's a very classical way how PNH is going to present to me, fine? So the patient symptomatology. Diagnosis is obviously based on clinical manifestation. I will have pancytopenia. The patient is most certainly present with an early morning hematuria, right? So if you are suspecting PNH, ask the patient to give the next day early morning urine, because the second urine what the patient is going to have will not have hemoglobinuria. So always give an early morning sample to test for this PNH test, fine? Next, you'll have thrombosis. It's kind of paradoxical, right? When I say pancytopenia, I should ideally have bleeding disorder. Platelets is gone. It should not cause clotting. It should not cause bleeding, right? We'll have a look at that also. Let's say that I'm having platelet here, right? This is a normal platelet. So against platelet, I'm having complement mediated lysis. Again, there are two possibilities, like my G6PD. I can have a complete lysis. Complete destruction can happen. When there is a complete destruction, it reduces my platelet count. I can have a part destruction. Let's say that partly it's undergone lysis. Same platelets, there's a slight damage. When there's a light damage, when there's a part lysis, it will cause contact activation. Because contact activation of platelets, this will cause thrombosis. Thrombosis is the most common cause of death in PNH. Most of the time, PNH can present as an Budd-Chiari syndrome. And they can present as a Budd-Chiari syndrome, which is a hepatic vein thrombosis. There's a presentation finding, and I can also lose the patient with stroke manifestations, fine? So we have to know about this thrombosis as well, fine? So I have pancytopenia with thrombosis, then my diagnosis of PNH is more or less sorted, fine? Again, lab diagnosis, peripheral smear no finding, CBC no finding, everything is going to be completely normal apart from pancytopenia, right? CBC will show me pancytopenia. Peripheral smear more or less normal. I won't have any clues. The only thing which might help me a little bit here is your flow cytometry. I do have few other investigations as well. I'm going to write the other investigations, which is not done these days, but if it comes in an exam, do know it. We had old tests called as sucrose lysis test. Again, not used anymore. Or an HAMS test, acidified serum lysis test. Okay. Acidified serum hemolysis test, HAMS test. Again, these are all not used. They were old tests, they are obsolete. What these tests do is, I'm going to simulate the same situation, what I see in a real life, inside the body. I acidify them and make sure the hemolysis is present or not. Now the protocol is, you suspect PNH. The next thing you're going to do is flow cytometry. Okay, there are two things in flow cytometry. See, flow cytometry is a procedure. I can use any different stain there. Like for hereditary sclerosis, we used your eosin 5-maleimide, right? I can use any stain here. So what stains I use is, I have two types of stains. One, I am going to use my CD55 and 59 flow cytometry. This will be completely absent. The staining will be absent. Once my staining is absent, I suspect PNH, because 55-59 is absent means has to be PNH because they are not stuck. The other way of flow cytometry, that's also flow cytometry, called as flare. See, flare is a stain, that's all. It's called fluorescent aerolyzer. Fine. It's called as a fluorescent aerolizing stain. It's a flare stain, right? So here, when I use fluorescent aerolizing, this binds to GPI. So this also will be negative or absent. Both are based on flow cytometry. Now tell me, which you think is better? 5559 or flare? Obviously flare is better, right? Because it directly targets my target protein of GPI, right? But 55 and 59 also have close to 95-98% sensitivity. Flare is an expensive dye. 5559 is a cheaper one, so generally we go for a cheaper alternative, that's all, right? But both are flow cytometry based principle only. I'm not having any new additional tests there, okay? So I know how to diagnose them. Fine. Treatment, you do have a drug, one of the most expensive drug called as eculizumab. It's the most expensive drug I think present as of now. Eculizumab is a C5 inhibitor. It stops the formation of MAC complex. So the main use of eculizumab is it will reduce the incidence of thrombosis. It said that it reduced the incidence of thrombosis up to 75 to 80% reduction in the incidence of thrombosis. So it's kind of life-saving, right? Complication is more worrisome for PNH. It's an acquired mutation of the stem cell. So I can have two complications. It can progress to an aplastic anemia. The entire stem cell can become abnormal. The clone can survive, become aplastic anemia, or it can become to leukemia. Leukemia transformation, most likely AML, can become an acute myeloid leukemia. These two are known complications of PNH, so that becomes troublesome for us to handle the patients. Fine. Okay, that's in short about PNH. Okay, so we have discussed few hemolytic anemias today, and we did discuss about iron deficiency anemias today. So this is the Study With Me series, where we'll be having discussions on daily around 5 p.m. Okay, where is that? We'll look at WBCs tomorrow, and hopefully we'll be able to see few lesions of WBCs tomorrow and day after, and maybe at the end of the day, end of 4 days, we'll have a 20 MCQ questions on the Unacademy app. Hopefully you write that and we'll get all these concepts clear. Fine. So if any doubt, any point of time, you can ping me on my Telegram group or in my WhatsApp group, where Instagram, whatever social media is, I'll be able to reply to you. Fine. So that's it today. Thank you for your time. See you soon with WBC chapter tomorrow at 5 p.m. Till then, bye bye.